So good morning. I'm Professor Oliver Gao. I'm a Director of Cornell System Engineering. Today our guest is Professor Jyotishman Pathak. Actually, Dr. Pathak is Francis and Loeb Professor of Medical Informatics, Professor of Healthcare Policy and Research, and also the Chief of the Division of Health Informatics at Weill Cornell. So welcome, Jyotish.
Thank you.
So it's great to have you here. We know that now in today's world we are facing so many challenges, and these challenges are not only at the component level. It's really at the much bigger systems level. Mm-hmm. So can you start by kind of introducing yourself, because not just introduce your title, but you have achieved so much in your career yourself, and also in your view, what are some major key challenges to our human society in terms of healthcare or anything related to your area?
Sure. First of all, thank you for inviting me to visit Cornell University in Ithaca. So my background is in computer science, and I moved to New York about 2 years ago. Prior to this, I was a professor of biomedical informatics at Mayo Clinic in Rochester, Minnesota. My research primarily focuses on developing novel data mining techniques using patient electronic health records. Mm-hmm. As you have heard, patient electronic health records are becoming more and more prevalent these days. And my research team tries to analyze this data, which I would not necessarily categorize as big, but certainly much more messy. It's highly complex. The nature of the data contains a lot of missing information. There is lack of longitudinal data. And so we try to develop methods and techniques that can address some of these problems. I have a specific research focus in mental and behavioral health, and particularly in major depression. That is a very strong condition, and it is my belief that mental health impacts physical health, and physical health impacts mental health. So there is a bidirectional association between these conditions. And even in our own society, at many different levels, the government, the public, I think there is a strong recognition that mental illness is a huge problem in our communities, and we need to apply different methods and interventions to help our patients who are suffering from mental illness. So my research tries to focus on identifying patients who are at high risk for depression, identifying therapies which might be most appropriate for a given individual patient, looking at their electronic health record information as well as genomic data. And last but not the least, we are trying to answer some questions from a health policy point of view in terms of looking at what are the different policy, how we can help and inform different policymakers in terms of making access to mental health care services much more broadly available. So that's sort of my background. To sort of answer your next question, what are some of the challenges that our society are facing, and certainly in the context of health? I think there are numerous challenges, as evidenced from the recent news feeds that we are all very familiar with. There are strong healthcare policy challenges that us as a nation we are facing. But looking at this from a more micro point of view, I think we are at the crux of huge access to information, both from individual patients, from healthcare providers, from different health systems. And I think it's a very interesting opportunity to either be in the field of engineering or to be in the field of health informatics, that how us as non-healthcare providers can collaborate and work with healthcare providers to facilitate better patient care. At the end of the day, it's the needs of the patient that comes first. That's a motto that I learned back at Mayo Clinic, and I think it is still true. And it is our duty and our responsibility to help facilitate that agenda.
When we talk about health, we think of people, having cancer, mm-hmm. and people getting a cold, right? This kind of health issues, but this mental health, and I think it's now getting a lot of attention and momentum. So how big in terms of size of such problem, and also how pervasive such kind of mental health problems are without today's society?
Right. So there are many challenges when we talk in terms of mental health. I think one of the challenges is that mental health is highly underdiagnosed and in many cases underrecognized. So the prevalence numbers that, for example, the CDC quotes, in my opinion, are much more higher than what the data actually shows. There is frequently a stigma associated with mental illness, more of a personal stigma or a family stigma. And as a result, many individual patients, they try not to be more open and try to hide some of their mental illnesses. So I think prevalence numbers are actually much more higher. And unlike cancer, where of course there is a very strong environmental aspect to it, I think mental health takes it to a completely different level. The place where you live, the place where you work, your family environment, your income, the fact that whether you have disability or not, these are huge components that impact a person's anxiety and stress levels, and which in turn potentially impacts their mental and behavioral health. So in my opinion, mental health sort of takes not only what is happening with me as an individual, but what is happening around me and in my community, because there are implications which in many cases are not well understood. And my hope is that research activities going across our institutions would be able to address some of these questions.
So when we talk about mental health, of course, it's going to be very closely related to physical health. And also, I think you mentioned this kind of very close linkage between health, including both physical and mental health, to the environmental health, the living environment. So, and you indicated that through further research at higher education institutions, we can bring about some new solutions. So, in addition to research, what else do you think we need to address the huge and this kind of tremendous health challenge we are facing?
So I think there are several elements that need to be considered, in my opinion, to address this bigger problem. One is this challenge of implementation. So what do I mean by that? Us as academics, we of course want to do great research, have great publications, secure federal funding or other kinds of funding. But very frequently, the outcomes of those research projects are not necessarily implemented in a real world scenario. So for specific to mental health, let's say we developed a predictive model to identify patients who are at high risk of depression, major depression. How can we actually take that model and implement it within a small clinic, within a medium-sized health system, or a large health system such as Weill Cornell, that can be used by healthcare providers, by physicians, by nurse practitioners, and other clinicians in a day-to-day setting? That the transfer of knowledge from an outcome, from a research project to a real-life implementation, I think that the transfer of knowledge is not very prompt, it's not very rapid, and as a result, a lot of the great research is still in your closet. So I think, in my opinion, that is number one challenge. The number two challenge is, in some ways, the tension between the field of medicine as a whole and how interdisciplinary science can contribute in advancing the field of medicine. So, for example, nowadays we hear a lot of buzzwords about big data, about machine learning, about artificial intelligence. In fact, my presentation is going to touch on some of these topics. I think the community at large is still very unsure about how some of these approaches and how some of these techniques could facilitate better healthcare delivery. And it's rightfully, because we do not necessarily have several success stories, we have few success stories. But at the very crux of the issue is this tension between in some ways human versus machine. So if I take an extremely large data set and crunch it to a machine, it produces some results. Me as a provider, do I trust what the machine is generating, or do I trust my own instinct? Do I trust my 30 years of medical practice? Do I trust my own gut feeling? I think there is the tension that the data, the outcomes that a particular algorithm or a particular technique is generating is not as good as my human judgment. And there is some education that needs to happen, that it's not either or, but rather it is how machines and algorithms and tools can complement the healthcare delivery process. So I think, in my opinion, there is this educational component that needs to happen to train our future scientists, to train our future physicians, that how they can collaborate together in a much more team science-based approach, as opposed to individual science-based approach. And I think the third part that needs to happen, again, in my opinion, is a stronger culture of innovation, where academia is working very closely with industry partners. Because at the end of the day, it's the industry that is producing drugs, it is the industry that is manufacturing devices, it is the industry that is manufacturing different software tools. And if academic interests are not aligned with industry research and industry interest, it is hard to achieve my first concern, which is around translation. So to the extent we can bridge these two different worlds in a meaningful way, I think it'll take us further along.
It's more really kind of a cultural thing, right? How, for example, academic like professors, like you are expected to do advanced research, and one way to evaluate your research is this, publications. Mm-hmm. So as a result, people are cultivated and get used to a momentum that, I apply for funding, and I work with graduate students to work on papers. I get my papers published, I move on to next cycle of this. Mm-hmm. But I kind of lacking that very important third, challenge is kind of stronger culture of innovation, especially I think you emphasize this academic and industry collaboration, right? So how do you feel currently now the culture, say for example at Weill Cornell, in terms of cultivating or promoting this kind of like your research, and then with the industry?
Right, that's a great point. So I have been at Weill Cornell for about roughly 2 years. I just had my second anniversary 2 days ago. Thank you. So I am still very new. But my experience is that certainly Weill Cornell Medicine, and I think our university as a whole, has this very strong culture of cultivating that relationship. I think Weill Cornell is very uniquely positioned, being in New York City, to further capitalize on the opportunities that are there to explore industry-based collaborations. Just recently, there was an innovation fund RFA that was issued, a request for funding opportunity, which is precisely focused on how academic scholars and faculty would collaborate with, in this particular case, a pharma company, mm-hmm. for leveraging big data and large-scale information to help answer certain questions of clinical interest. So I think I'm seeing more and more of that sort of example, which sort of ties two very different agendas under a unifying theme. Is there more to be done? Absolutely yes. In many ways, I think that culture should also be grassroots driven, and that's where I'm very excited to what Cornell Tech is trying to achieve, and hopefully they will be very successful, is this embedding this culture of innovation at the student level. And so that it's not a top-down driven approach, but rather a bottom-up driven approach. Because then going to your earlier point, innovation becomes a metric against which not only students are evaluated, but potentially faculty are also evaluated for their promotion, tenure, and other aspects. And I think in sort of speaking outside our university, I think that there is a cultural shift that's happening. Implementation science, certainly within the National Institute of Health at NIH, is becoming a major theme. There are high-profile journals that are high-impact factors that are focusing on implementation science. There are NIH funding opportunities that are focusing on implementation science. So I think there's a recognition at an institutional level, at the state level, and at the federal level to break this barrier of how we can rapidly make our research discoveries implemented within certain healthcare settings.
I am too very excited about this kind of shifting,
Sure.
right? This culture shifting. It's really so we do research. In the end, we want to serve the society. We want to have an impact, and I think this implementation is right, at the critical point, linking our fundamental research
Right.
and the societal needs. So with this kind of, now I want to go probably a little bit deeper, like in your specific research area, this biomedical informatics or health informatics. So can you tell us more about kind of more specific underneath health informatics? What are the specific research areas, and what are the major like modeling or analytical tools that you use? Because I think this will be very useful for people like me outside of your research area to have a better understanding of the exciting work you are doing.
So our field of informatics, by definition, is a highly interdisciplinary field. We have a professional society called the American Medical Informatics Association, or AMIA, which is a strong body of clinicians who have expertise in certain clinical areas, computer scientists, computer engineers, statisticians, epidemiologists, health services researchers. So it's a very broader and a highly interdisciplinary field of activity. As far as our research is concerned, let me maybe first introduce briefly about our department and then certainly our division. So we are a Department of Healthcare Policy and Research at Weill Cornell. And our department comprises of faculty who focuses their research going from individual health to population health to all the way up to public health, making policies, our interest in health policies. We have, our department is comprised of 6 different divisions, and our health informatics division faculty are mostly interested in developing interventions that could be implemented at point of care, analyzing clinical data, patient data, for either that's for risk modeling or for understanding clinical workflow. And then when we talk in terms of implementation science, we also have to make sure that the implementation actually works. So we want to study how things that we have implemented are helping providers, are helping patients. So we have a very strong emphasis on human factors research and implementation science within our own group. In terms of tools that we use, many of us, and including myself, we have a background in computer science and information science. So we have very strong familiarity with database programming. We have very strong familiarity with statistical languages such as R, and I know that many of your students probably use MATLAB.
Yeah, we use R as well.
You use R as well, yeah. So we use R quite heavily. And then we have very strong expertise in Java and C++ in terms of sort of programming languages. Our sort of core expertise is in our department and in our group is focused on at least 3 major types of data. One is data that you could derive on a given individual patient from their electronic health records. The other kind of data set that we do a lot of research is looking at insurance claims data. So whether that is data that's coming from public insurance like Medicare or Medicaid or any private insurance plans that you might have. And increasingly, we have a very strong focus on looking at genetic information that is derived from whole genome data or whole exome data on a given patient. And for analyzing all of this information, you need different methods, you need different tools. So for example, we develop robust statistical methods for dealing with data imputation, dealing with missing information. We look at different machine learning algorithms for risk prediction, starting with some of the very basic algorithms that are out there, as well as developing new approaches. And then we also try to develop new visualization techniques for analyzing this data. I am of a very strong belief that before you actually start mining your data, you should try to visualize your data. Even if it's a raw data, you should try to visualize your data to understand what the data looks like, what are different parameters that the data looks like. So we try to quite heavily focus on issues around data visualization as well.
I totally agree with you. I think visualization is really actually very, very critical, especially I think from a informatics research point of view, right? So I think the informatics will in the end serve a purpose, serve some client. Even though kind of from the data analytics, you get a lot of insight. However, if this insight is not very well communicated to a decision maker, right? I think that still it's equal to nothing. That's why I totally agree with you. I think this kind of realization and how to display data is really very important. So you mentioned that you work on like 3 types of data, EHR, and also you talk about insurance data and you talk about genetics data. So I'm sure, of course, at the very beginning, all these data sets, they might be very messy. You clean that up. So how, this probably I think bring to something related to your talk today, how do you go from these kind of seemingly unrelated data sets and through your beautiful work of science and art, and you bring all these things to a certain level of insights or guidance? So how do you change the messy data into insights?
That's $1 million question.
Yes.
I think a lot of this is very hard work. So let me give some classic examples. So electronic health record data comprises of information like your demographic information, your lab results, what kind of drugs you are taking, what kind of diagnosis that you are having. If you are familiar with a relational database, a SQL database, you think in terms of tables. You have different rows, you have different columns. About 70% or at least 60% of data in a given electronic health record are not in a structured way. So a lot of the data is stored as what we call as unstructured information. So which means it's like your email that I visit a doctor. They are gathering my history, they're gathering my symptoms information. It is all typed like a free text. That is easy for a human being to understand when I look at the text, but it is very, very difficult for a machine to understand. So we spend a lot of time in extracting structure from that unstructured text. So there is a field of research called natural language processing, or many areas of information retrieval call them as text mining. That's how your iPhone works, your Siri works. You are talking natural language, and in this case, your iPhone is processing that data. So we develop similar methods and techniques to process that information and essentially generate structured data that can be, for example, incorporated within a SQL database for subsequent analyses. So that the process from going from a highly unstructured information, highly messy information to a much more cleaner cohort, in my opinion, it is almost 70 to 80% of work. And while we have come up with different techniques, and likewise many of my colleagues have come up with different techniques, at the end of the day, it's a highly labor intensive and highly manual work because every electronic health record system is different. So the method that you have developed for one institution may or may not be applicable for a different institution. So we have a group of research fellows, we have a group of research assistants, research coordinators, data analysts who spend countless of hours in making this data set clean. And it might be that there is a room for innovation here because the approaches that we might have used are perhaps more naive, are perhaps more archaic, and there is some opportunity for more advanced techniques. And we have developed such techniques, but it is, at the end of the day, it is still a very labor-intensive work.
You mentioned like kind of this, you work on this data from different sources, and you have like research associate, postdoc, grad student. We spend, you say, 70-80% of the time probably working on this data. That kind of pushed me to think about, like in my field, in transportation or even in civil engineering, like when we build these kind of buildings or when we design cars, right? There is, of course, in the very beginning, for example, buildings in India and China, they're built in a different way than the buildings built here. Cars are built across different places. They are using different standards. But of course, I think you mentioned there is this American Society of
American Medical Informatics Association.
Yes, that I think this association. So I'm thinking about the reason why we have to spend so much time working on this data, because this data, they were not recorded in a standardized protocol. So now you have this association. So kind of in the longer term, would that be possible to, through your own research, of course collaborating with this association, could we create some kind of medical record protocol? Or like kind of, for example, for internet communication, network design, right? We have these internet protocols.
Right.
So for this kind of healthcare system, how can we kind of transplant or learn from other fields and move that to that area?
Absolutely. It's a fantastic question. And the answer is it is very hard to achieve the equivalent of an HTTP protocol. So AMIA, which is the American Medical Informatics Association, is a professional society for academic informatics and for industry to share their research outputs, to share their educational initiatives. AMIA is not the body which is developing these essentially protocols or healthcare standards. There is another organization called Health Level 7 or HL7, which is the professional society where many of these healthcare standards are being developed. So for example, how should we represent demographic information consistently across institution 1, institution 2, institution 3? How should we represent lab results consistently across multiple different electronic health record systems? So entities like HL7, and there are other entities as well across the federal government who have proposed these different standards. However, these standards are not always well adopted for a variety of reasons. Either because it's cost prohibitive. If I have developed a system in 1970 when there was no standard, and now there is a new standard in 2017, it might be very expensive for me to transition into the new system. Some institutions are able to do that. Some institutions do not have the financial resources to do that. So adoption of the standards is a big problem in our space. Having said that, a few years ago, during the Obama administration, there was an act that was passed called the High-Tech Act, which introduced this concept of meaningful use of electronic health records. So what it allows you to do, or what meaningful use was really focused on, that it's not sufficient for us to have data in our electronic health record system, but we have to demonstrate how the data is meaningfully used, either for research, but their focus was primarily for clinical care. So the meaningful use required that different healthcare providers, different health systems adopt these standards in their own system. And so that was in my opinion, that was a very successful few initial years. And although the meaningful use journey had many hiccups, I think that sort of started some baseline in terms of how data standards need to be applied. But I think there's a lot of work to be done. And while I might start using standards today, my historical data is still not standardized. So in fact, there is a huge research community which is focused on how to make data more standardized across different health systems. And it's a very hard problem to solve.
I think it is a very hard problem to solve. And actually, it kind of naturally leads me to my kind of next question. So we have talked about these key challenges, and we dived a little bit into the depths of your own specific research, where we identified some specific kind of either from at the data layer or at some technical layer, some problems or challenges. So with all these challenges, what do you see as possible solutions? Near term, longer term?
That's a tough question to answer. In my opinion, I think the near-term solutions, where at least I'm trying to focus, and hopefully many of my colleagues are, is that we really need to push the boundary to something that I touched earlier, is we want to narrow the time that it takes from discovery science to implementation science. So it's one thing to come up with the best performing machine learning model, but as we discussed, if nobody uses it, there is no value to it. So in my opinion, there needs to be very strong emphasis in how we can implement and apply these different techniques in a real world setting and see what works. Maybe the best algorithm that performed in a controlled lab setting doesn't work well in a real world setting. Maybe you need something more simpler. Maybe the best data mining algorithm that you developed is uninterpretable. So in other words, clinicians cannot make any decisions based on that. So it doesn't work. So we have to do these sorts of experiments in taking the research outcomes and trying them in the real world setting. And those institutions, those research labs, and those research teams who are able to do that, I think are going to be very successful, because you learn from those experiences and then in turn improve your own research. So I think that's in my opinion a very immediate and short-term objective that we are certainly working, and many of my colleagues are also working. From a long-term point of view, I think there are certain policy changes that need to happen within our society and within our country, and by that I mean the culture in terms of how team science is accomplished in different institutions, how the government and funding agencies promote team science, I think is going to be highly crucial. Certainly, in my experience in healthcare, gone are the days when I can just close my door and have a data set and I just mull over the data set on my own. I don't think that is a very successful route. In fact, I have to open my door, go to a different building, establish collaborations. So there has to be that culture that promotes this level of team science across different faculty, across different departments, across different schools, and ideally across different universities.
Including coming to Ithaca.
Including coming to Ithaca, thank you. And to my earlier point, universities and industries. So I think there needs to be certain cultural and policy changes that have to be developed at the leadership level that can foster this type of collaboration, that can foster this type of activity. And only then I think we can achieve my short-term goal for rapid implementation.
And also I'm thinking about, right, so when we talk about health, we talk about healthcare. We're essentially talking about now we have these patients, they're sick, and how can we cure them or how can we reduce the pain of these patients. But if we think further from a societal point of view, right, healthcare is really a big chunk of our societal cost. And we are always, for example, nowadays I'm telling my kids, an apple a day keeps the doctor away. So what I'm when we talk about healthcare, where basically it's like kind of something bad has already happened, and we have you coming for rescue to take care of this. However, how can we prevent this? What would be some fundamental preventive approaches? That's, for example, we're talking about the center. Now I'm directing the Center for Transportation Environment and Community Health. And I'm a believer that I feel cities and our living environment, our built environment, they interact, as you mentioned earlier, they interact with our genetics and our, inner self, but, exposed to this outer environment. They interact. So in the longer term, what do we need to do in terms of kind of revolutionize our paradigms in planning, design, and managing our living environment, so that that healthcare is no longer about like you and so many doctors that you are occupied by so many incoming patients. Instead, you have your effort even up higher at a further stage, at the earlier stage of this chain in this medical care.
Absolutely. I think the golden rule here is that prevention is always better than cure. So the earlier we can identify something and prevent a particular condition, not only it is good for the patient, but it is also less expensive, and ideally it can lead to better outcomes. So if you think in that ways, that prevention is always better than cure, so then we are not just talking about health, we are talking about health and wellness. And the moment we introduce the concept of wellness, the elements that you just described in terms of the surroundings, the environment, my work culture, my workplace, my family relationships, these all start playing a role. A person who has high level of quote-unquote wellness is perhaps keeping a lot of these things in balance and is enjoying good societal connections, is enjoying good personal connections. And that leads to a high level of health and wellness. In my opinion, I think it is hard to measure. So one of the challenges in how we can identify if someone is well or not is to measure how the person is doing. And it is hard to measure wellness. Yes, I can use my iPhone or I can use my smartwatch, but that gives us a very small fraction of what is really happening with my life as a whole, or a given individual's life as a whole. So there has to be more broader perspectives in terms of the society and in terms of in the workplace that can facilitate a person's wellness. So as we have talked earlier, how, for example, departments of transportations across different countries could embrace the concept of health and wellness as they are planning bus routes or as they are planning routes for ambulances to travel. Because transportation is a huge aspect for someone's wellness, and lack of access to good transportation is a major barrier. And so to improve wellness, we have to take these external factors into consideration, which again brings back to my earlier point, is the nature of a holistic view as opposed to a microscopic view of our human health, which in turn requires us to have highly interdisciplinary activities across these spectrums of work.
That's wonderful. Actually, you mentioned this, holistic view, and that's actually essentially the keyword of a systems approach, right? We take a holistic view and taking into account something that was previously out of boundary, but now we incorporate this within the boundary of a complex system so that we can design our solutions not only to solve problems nowadays, but also there will be sustainable approaches to deal with some even unintended consequences. Right. So yeah, this is great. Thank you, Jyotish. I think we're all set.
Thank you very much.
Thank you for the insight.
Thank you.
I think this is really